Hi, I'm Dr. Dixon Mukombo, and I'll be presenting to you a lecture on approach to paraplegia and spinal cord disorders. I'd like to state from the outset that I took the original slides from Professor Diana's presentation. I've made a few edits to this presentation. So firstly, what is paraplegia? Paraplegia is an inability to move bilateral lower extremities. Then there's another term which we often use interchangeably, but they actually mean something different. That is paraparesis. Paraparesis simply means there's weakness in the bilateral lower extremities, but there is movement to a certain degree. But in paraplegia, there is totally no movement at all. So it's important to get these two correct and not get them mixed up. However, they mostly used to refer different grades of severity of the same disease. So where do we localize paraplegia? So paraplegia can be localized, I guess, anywhere in the central nervous system, and the peripheral nervous system. Though commonly, it tends to be localized to the spinal cord. So here are examples of some of the localization, and those which are bold are the ones which are going to be discussed in this presentation. So in the brain, paraplegia can come about because of lesions in the midline parasagittal area where the homunculus represents the legs of both motor cortices. So bear in mind, it has to involve both the right and left hemispheres for both legs to be weak, since paraplegia is the weakness of both legs. So common things that can cause this in the brain are arterial communicating artery aneurysm or a meningioma in the falx cerebri in the midline. So the next localization is the spinal cord. Bear in mind, this is still in the central nervous system. Then from the spinal cord or within the spinal cord, you have the anterior horn cells, which can be separately or preferentially affected and have a rather different picture. So these are conditions like which cause acute flaccid paralysis, such as poliomyelitis, as well as many viral spinal cord disorders. So the other localization is the peripheral nerves, and this is commonly seen in acute inflammatory demyelinating polyradiculopathy, commonly called GBS, or the chronic form of GBS, a CIDP. We'll not discuss this in this presentation. I believe you will have a lecture either after this one or before this. You could have had a lecture on AIDP. Then the other localization of paraplegia could be neuromuscular junction disorders, and these include, but not restricted to, myasthenia gravis and Lambert-Eaton myasthenic syndrome. Then the muscles could also be preferentially involved, and they could cause paresis or paraplegia. So it's important to know that when you are seeing a patient with paraplegia, you really have to tease out and see where exactly the problem is arising from, even though the common cause of it, as I said earlier, is the spinal cord. So we'll start this in a rather interactive way, but I'll understand that this is a pre-recorded presentation. So in our first case, we look at a 29-year-old man with no significant past medical history, HIV negative, who presents with a 4-day history of progressive numbness and weakness of his legs. So the question we would ask is, what would you want to know? What further history would you want to get? Then after you get your history, what is your hypothesis about the localization before you start the examination? Like, where do you think this man's problem is arising from the things we passed through earlier on? So this is his examination. His mental status, language, and parental function were normal. His cranial nerves were normal. On the motor exam, his bulk and tone were normal. His strength was normal in the upper extremities. At the hip flexors, it was reduced 4 out of 5, and the knee extensors were also reduced, as well as the knee flexors. And then dorsiflexion and plantar flexion were 3 out of 5, both lower limbs. The reflexes were 2+ in the biceps on both upper limbs. There are 1+ at the triceps that is reduced, and the brachioradialis was also 1+. They were absent in both lower extremities, that is the knees and the ankles did not have any reflexes. The toes or plantars were downgoing, which means there was no Babinski. So sensation was decreased to all modalities from the feet to the knees, and coordination was normal. On his gait, he had a foot slapping gait and difficulty with walking on the toes and heels. So where do you localize after this examination? So this should be a general guide to localizing a motor exam, regardless of whether you're thinking of paraplegia or you're thinking of a stroke situation. I believe this is an important guide which you have to have in your mind when you're trying to think about the localization of your motor exam. So you look at the tone and you want to divide the presentation of your patient into whether it is upper motor neuron or lower motor neuron. So if the tone is increased, usually points to upper motor neuron. If there are no fasciculations, upper motor neuron. The bulk is normal, upper motor neuron. Reflexes are increased, upper motor neuron. An upgoing plantar or Babinski, upper motor neuron. Then the converse is, of course, true. So looking at our patient's presentation, we see that his tone was rather normal. So on lower motor neuron, it can be hypotonic or normal. His bulk was equally normal. He didn't have fasciculations. Then his weakness pattern was more distal greater than proximal. At least we are having something that's guiding us somewhere. His reflexes were hypo and absent. And then the Babinski was downgoing. So we see that even though it's not everything in the lower motor neuron category that is found in our patient, but we find that we have a substantial amount in the lower motor neuron parameters for us to classify his presentation as a lower motor neuron presentation. So further on, this table will try to help us narrow down into which part or which pattern is affected. So if the nerve roots are affected, usually have loss of sensation or weakness in a radicular pattern. So radicular simply means along a nerve root. Then in terms of a problem affecting a named nerve, so this is a nerve like the ulnar nerve or the median nerve, you have loss of sensation in a dermatomal distribution and weakness in a named nerve distribution, and it's often asymmetric only one side. So for peripheral nerves or a polyneuropathy, usually you have a stocking and glove distribution of sensory findings or weakness of sensory findings. Then in terms of neuromuscular junction disorders, often you have symmetrical, proximal, weaker than distal with fatigability on exam if you test for it, as well as bulbar muscle involvement. Then if it's a muscle problem, it's usually symmetric as well, but with proximal involvement more than distal involvement. Our patient had distal involvement more than proximal involvement. The only difference with the neuromuscular and muscle is that you would be unable to elicit fatigability with the muscle problem. So our patient's pattern is seeming to fit more into the peripheral nerves of polyneuropathy pattern. So what is your differential diagnosis now? So this is a list of the differential diagnosis, which I came up with. You could add a few more. And on top of our list, given the fact that it is an acute presentation, which is progressing, you think of a GBS. Other things to consider: a chronic inflammatory demyelinating polyneuropathy in its early stages. An acute myelopathy could also be considered if it has not yet ascended enough or have developed a clear-cut sensory level. HIV infection can also be considered, as well as these other differentials down there. So the diagnosis in this patient eventually was supposed to be or was GBS. And as I said earlier, we're not going to discuss GBS in this presentation, to be discussed elsewhere in the course of your neurology lectures. So we move on to the second case, which is similar to the first one. It's a 29-year-old HIV negative man who presents similarly with a 4-day history of progressive numbness and weakness of his legs. We ask the same questions. What do you want to know? What is your hypothesis about the localization of this patient's examination? So on exam, his mental status, language, and parietal function were normal. His cranial nerves were normal as well. On his motor exam, his bulk was normal. He had spasticity noted in bilateral lower extremities. So that means his tone was increased. The strength was 5 out of 5 in the upper limbs. It was 4 out of 5 at the hip flexors and the knee flexors, both lower limbs. It was 3 out of 5 with the ankle dorsiflexion. Hip extension, knee extension, and plantar flexion were normal. So he had a flexor predominant weakness pattern where the extensors were spared, but the flexors were weak. Reflexes were 2+ in the upper extremities. There were 3+ at the knees and patella, and the right toe was upgoing. Sensation was decreased to all modalities from the feet to the knees, and he also exhibited a T5 sensory level. Coordination was normal. His gait was scissoring, unlike the first one, whose gait was a foot slapping gait. So where do you localize this problem of this patient? So we go back to the same schema which we used in the earlier case, and this is a schema you should use with every patient who you do a motor exam. With the findings you find on the motor exam, you have to go through this in your mind every time. So this patient had spastic tone, his back was normal, he didn't have fasciculations, his weakness pattern in the lower extremities, his flexors were weaker than the extensors, just as it states here. So for this greater sign, it's usually depicting the weakness. So if it says flexor greater than extensor, it means the flexors are weaker than extensors. The reflexes were hyper and his toe was upgoing, low in one limb only in the right limb. So his presentation fits with an upper motor neuron presentation. Then in the upper motor neuron, how do we localize? So if it is in cerebral hemispheres, that is in the cortex, you have cortical features that are displayed in the table, of which you didn't have any. If it is in the cerebellum, you have these few cerebellar features. We know they're not limited to these: ataxia, dysmetria, and it didn't have any cerebellar features. If it's in the brainstem, you have cranioneuropathies, and then you have cross motor and sensory findings. You didn't have this as well. If it's in the spinal cord, you have paraparesis. Sometimes you could have quadriparesis if it's higher up. You will have cross-sensory findings. You have bowel bladder dysfunction and spinal sensory levels. So it's not always that you find all these, but if you find more parameters fit in one category than any other, therefore it will lead you to thinking the localization is in that area. So our patient had paraparesis. He also had a spinal sensory level. We didn't ask further history about bowel and bladder, and we would safely say that his upper motor neuron findings are consistent with the spinal cord localization. Then later on, we'll see that we can also localize in the spinal cord in terms of segment. Is it the cervical, thoracic, and lumbar? Though his case would be thoracic and below, because his upper limbs were relatively spared. So our differential diagnosis is the differential diagnosis that comes with transverse myelitis. Bear in mind that transverse myelitis is not a differential. It's a description of a broad theme where we're saying that most of the spinal cord, like a cross-section of the spinal cord, is wholly involved, and we think it's inflammatory. So transverse myelitis is not a diagnosis, but it is just a description of the presentation. It's more like saying anemia. Then you have to state the causes of anemia. So these are the possible differential diagnoses for a transverse myelitis presentation. They could be infectious, which is a whole myriad: viral, bacterial, fungal, parasitic. They could be inflammatory or autoimmune, which also has a broad differential. They could be mechanical, compressive, which also has a differential, or could be traumatic. They could also be metabolic, and there's an array of metabolic causes. Could there be vitamin deficiencies? Could there be toxins? Could there be heavy metal intoxications? And they could also, of course, be vascular. Remember, the spinal cord, just like the brain, can also have a stroke and can also have a myriad of vascular presentations that occur in the brain. So we do not go to the actual diagnosis of this patient, but we'll end at transverse myelitis, and you'll need a wake-up for us to know exactly what was causing his transverse myelitis. So we'll delve in and go a little bit off tangent from the cases and talk about acute flaccid paralysis. So acute flaccid paralysis, this is a sudden onset of weakness or paralysis in any part of the body, most often occurs in children less than 15 years old. And anterior horn syndrome is the most common presentation in the acute flaccid paralysis umbrella. Fulminant transverse myelitis or spinal cord trauma are also possible. So infectious processes that preferentially affect the anterior horn cells of the spinal cord include, but are not limited to, polio, enteroviruses, echoviruses, which now adenoviruses, or botulism. And the anterior horn cells are basically nuclei of lower motor neurons, which are located in the spinal cord. So it is important to differentiate it from GBS or AIDP, which, as I said again, will not be discussed in this presentation. And the main difference is that the CSF is usually inflammatory. In anterior horn syndrome, there's more pleocytosis, and that is in GBS. Sorry, the CSF is usually inflammatory in GBS. There's more pleocytosis as opposed to in anterior horn syndromes. And EMG and nerve conduction studies are often normal in GBS. So on examination, in acute flaccid paralysis, you find that the patient is hypotonic, flaccid, paraplegic, or even quadriplegic. The reflexes are absent, and Babinski is often equivocal. So it usually presents as an hyperacute or fulminant transverse myelitis with trauma or with anterior horn diseases. There's loss of sensation below the level of the lesion and the spinosensory level with bowel and bladder incontinence. So we delve in just a bit into one particular cause of acute flaccid paralysis that is important to mention, and this is poliomyelitis. This is caused by a poliovirus and occurs in 0.5% of infections. So not all poliovirus infections result in poliomyelitis. That's important to note. 70% of people affected are symptomatic. 25% have minor symptoms like fever and sore throat, and 5% have a headache. And remember, only 0.5% of these infections will develop poliomyelitis. The clinical presentations, most common CNS manifestation is a septic meningitis. Acute flaccid paralysis is most dangerous form of CNS polio presentation. So acute flaccid paralysis is life-threatening because of diaphragmatic weakness. Many have permanent neurological disability after an attack of acute flaccid paralysis. Then you can also have a post-polio syndrome as a presentation of poliovirus infection. So this is a reemergence of prior weakness or development of new weakness many years after the initial infection. So the treatment of poliomyelitis is often supportive. Now we delve into the next part of our presentation, that's spinal cord disorders. And as you see, it's adapted from Professor Diana Sila's presentation. So we'll start off with a review of the anatomy. So what you're seeing here is basically a schema of the different tracts that are in the spinal cord. So on top is the posterior segment, and below is the anterior part of the spinal cord. And what you see are the various nuclei, which I'll have you look at in your own time in detail, but they're important in localization of presentation. And then on the right side is a schema of two pathways. This is the dorsal column medial lemniscal pathway. That's the first one, where the sensory information which travels from the periphery, it could be from the toe or from the fingers for vibration and proprioception mainly, travels and crosses, travels and enters the spinal cord on the same side, ascends up to the level of the medulla and crosses over to the opposite side and goes to the primary sensory cortex of the opposite side. So this is in contrast to the spinothalamic tracts, which are more anterolateral or just lateral, where the information from the sensory nerves crosses almost immediately to the contralateral side of the spinal cord and then is interpreted on the contralateral side of the sensory cortex. So this is important to know these pathways because they help in the spinal cord syndromes. So looking at the vasculature of the spinal cord, you have the anterior spinal artery, which, as the name suggests, is anterior and supplies both sides. So there's one anterior spinal artery which supplies both sides of the anterior spinal cord. And then you have two posterolateral spinal arteries, which each supply either side of the spinal cord. And the venous drainage has 3 anterior and 3 posterior spinal veins. They are drained by the medullary and radicular veins, and they join the internal vertebral and venous plexuses in the epidural space. So this anatomy, vascular anatomy, is especially important when it comes to stroke syndromes of the spinal cord. So do remember that the anterior spinal cord is unpaired and the posterolateral arteries are paired. So how do spinal cord disorders present? So the presentation of symptoms is referable to a focal lesion in the spinal cord. So the motor manifestations are mainly paraparesis or paraplegia as the most common one, but can also present with hemiparesis or quadriparesis. The sensory findings are usually crossed findings, crossed with respect to the spinothalamic and dorsal column distribution, and there's often a spinal sensory level. Then often, but not always, you could have bladder and bowel dysfunction. Often and not always, gait and balance abnormalities are also noted. And of course, autonomic dysfunction is also a feature which is suggestive of spinal cord involvement. So the examination of a spinal cord paraplegic patient who and could have acute paralysis, and note that this occurs in the hyperacute or fulminant stage of transverse myelitis or trauma on anterior horn cell. But this acute presentation is usually short-lived for true spinal cord pathologies. Then there's usually loss of sensation below the level of the lesion with the spinal sensory level, and then bladder or bowel incontinence could be found on examination. So further exam, usually after the acute hyperacute stage of myelitis or traumatic spinal cord injury, you would now have upper motor neuron pictures coming, and this is the commonest presentation of spinal cord lesion or disorders. So they will have spasticity, weakness, mostly in the upper motor neuron pattern, as we said, where in the upper limbs, the flexors are stronger than the extensors. In the lower limbs, the flexors are weaker than the extensors. There's a periflexor and upgoing toes. There's also loss of sensation below the level of the lesion and the spinal sensory level, and bladder and bowel dysfunction. So I think I would have you look at this table, but it's a good table which will help you distinguish acute myelopathy from the mimics of acute myelopathy. It's really a good one to look at. It's self-explanatory. So I'll have you look at, I'm sure you have access to these slides after the presentation is done. This is another table which is worth looking at. I think you can find such tables in most textbooks. So you can look for clinical presentations of acute spinal cord disorders. I believe this is a very, very, very important table. I would wager even for the MCQs, you could find a few questions which try to talk about these spinal cord syndromes. So how do you approach the differential diagnosis of spinal cord disorders? We usually tend to look at it in terms of 3 frameworks. So firstly is the etiologic category. Then you look at it in terms of time course, and then you look at it in terms of anatomy. So we'll go through these frameworks for coming up with a differential diagnosis of spinal cord disorders. Often it is the integration of all these that helps with the diagnosis, but at times you can find that just by utilizing the etiological categorization, you'll be able to come up with a diagnosis. At times, just using the time course alone, There are a few classic presentations where the time course will just tell you that this has to be this differential and the anatomy. But oftentimes it is often helpful to combine these frameworks of approach. So the etiologic category mainly looks at the cause of this spinal cord disorder. Is it mechanical, vascular, demyelinating, autoimmune, infectious, parainfectious, paraneoplastic, neoplastic, or metabolic? I feel mnemonics would be helpful in this one as well. And I feel and I do know there are a number of mnemonics you could look up, which could help you narrow down with this etiologic categorization of spinal cord presentations. So we'll start with mechanical. So mechanical usually means or involves trauma. And this is an MRI depicting some of these mechanical traumas and how they would impact the spinal cord. And largely the presentation of mechanical injury to the spinal cord is really broad as the trauma can be from any side. You could have a Brown sequard where half of the spinal cord is affected. You could have a posterior cord syndrome where the trauma only affects the posterior cord. You could have that wide presentation, but often there's a history of obvious trauma in the history. So on the infectious or parainfectious, patient often systemically unwell. Yeah, you have a history of a chronically ill patient, could even be acute, but there'll be systemic unwellness with fever. There could be a rash, confusion, meningismus could be there, or concurrent systemic infection. And then it is often important to get the immune status of the patient. Are they immunocompromised or immunocompetent? Because the differential of the infectious or infectious agents sort of tends to differ slightly between the immunocompromised and the immunocompetent host. Travel and exposure history is often very important in infectious or infectious etiologies. So again, this is a table which lists the myriad of infectious agents that could affect the spinal cord. I'll just highlight a few. In the viral category, HIV is important. HTLV1 particularly is important. HSV is something to mention. Even though we do not test most of these in our acute spinal cord presentation, but it is important to also be aware of these other viruses. In terms of the atypical bacteria, TB is an important one to know. Treponema pallidum, very important to know in our area, just as TB, and because both can present with any spinal cord syndrome we could think of. Then parasites, I think worthwhile of mentioning here is schistosoma, of course, Mansoni, because we have a high burden of schistosomiasis. It would be a worthwhile posit that there would also be a fair amount of spinal cord schistosomiasis as well. Then in terms of the viruses, VZV is the most common cause of myelitis among the herpes viruses. Usually occurs in the setting of a zoster rash and also tends to occur more in the immunocompromised host. HSV2 is more common than HSV1, and usually the picture here is of a recurrent painful myeloradiculitis, mostly the lower thoracic cord, conus or cauda equina. May occur with or without the rash, and can affect both the immunocompetent and the immunocompromised, immunosuppressed host. CMV tends to present with an ascending radicumyelitis, intrinsic thoracolumbar myelitis, or rim-enhancing intramedullary lesion imaging can be seen. So HTLV is also a common cause of spastic paraparesis, endemic to Central and South America and parts of Africa. As you can see, I think it would be reasonable to assume that we do have cases of it in Zambia, only that we do not test for it because our neighbors have it both above us and in the southern direction as well. Its transmission is hematogenous, also sexual or from breast milk, mainly by bodily fluids. It has a predilection for the thoracic cord and the lateral corticospinal tracts and spinocerebellar tracts. It presents with lower extremity spastic paraparesis and early bladder involvement, and often gives a chronic picture. This is a patient who comes with a slowly progressive paraparesis or bladder involvement. On CSF examination, you find that there's pleocytosis with atypical lymphocytes. HTLV antigens and antibodies have low sensitivity, unfortunately, and there is no effective treatment for it. Then HIV vacuolar myelopathy is an important cause of paraparesis. Usually occurs after development of AIDS. It was more common in the pre-heart era, with 5 to 25% of patients being found with vacuolar myelopathy. And on autopsy, it was found to have even higher incidence of 25 to 55%. Survival is usually less than 6 months after diagnosis. And as you note, after the introduction of antiretroviral therapy, the cases have declined to less than 10% of patients with AIDS. So in terms of presentation, this presents with a slowly progressive lower extremity weakness, stiffness, and sensory loss. Gait difficulties and imbalance are often encountered in these patients with sphincter dysfunction. Upper extremity involvement is a late feature. And then mainly on examination, we find symmetrical upper motor neuron findings, usually without any sensory level. And then the lumbar puncture or CSF studies are often unrevealing. And then on imaging, you find that the posterior column involvement is predominant. So this is what a typical MRI would look like, with the posterior columns being pointed out by the arrow on the axial segment. And this is a longitudinal segment showing a hyperintensity in the posterior part of the spinal cord. Longitudinal extensive over 2 segments. And then this is the histopathology, where you find nerves with vacuoles asymmetrically distributed among them, and pallor of the myelin. So the other infection which we can mention is mycoplasma, which is an atypical bacteria, usually occurs in the setting of respiratory illness, likely due to inflammatory reaction and direct infection. It's a common cause of acute demyelinating encephalomyelopathy, which we'll discuss a bit further. Often presents with a longitudinally extensive transverse myelitis. So which means that the longer segment of the spinal cord is inflamed, and it cuts across the whole cord. Diagnosis is often difficult because PCR is insensitive, and it's difficult to culture mycoplasma. It is an atypical bacteria. Antibodies can also be present past infection, so they may not be helpful to know whether it's a previous infection they're depicting or not. So treatment is usually with the macrolide for respiratory infection, but quinolones and tetracyclines may have better CNS penetration. Concomitant steroids are often indicated. Syphilis, of course, is an odd fall, which is well known and classically described. And with the spinal cord, we tend to focus on disorders like tabes dorsalis. This is where there's progressive degeneration of the spinal cord, particularly of the dorsal columns. Then most common form of spinal cord syphilis infection is lytic meningomyelitis. This is where it affects the meninges around the spinal cord, and also inflames the spinal cord itself. Cervical thoracic cord presentation with symmetrical long tract signs is the common presentation. Then on imaging, you scan to see hyperintensity of the cord with swelling of the spinal cord. Then other things you could see is thickening of the meninges or a spinal cord gamma or an infarction. Pott's disease from TB, in the spinal cord, we tend to think more of tubercular spondylitis. That's the, you could say, medical term for it. It occurs in 1 to 2% of TB cases and accounts for 10 to 15% of extrapulmonary TB manifestation. Most commonly found in the thoracic spine, with 40 to 50% in the thoracic region, usually in the lower thoracic segments. But you could have it in the lumbar spine as well with 35 to 45% prevalence, and fewer cases in the cervical spine with 10%. Hematogenous spread to 2 consecutive vertebral bodies with loss of nutrients to the intervertebral disc and collapse of the disc space and vertebral body, which leads to spinal cord compression. This is often the progress of events or pathophysiology of Pott's disease and subsequential spinal cord compression, which leads to spinal cord myelitis or myelopathy. So the clinical presentation is often of a non-specific back pain or radicular pain for several weeks to months, and half of these patients will present with neurological deficits. Paraplegia is the most common, or Cauda-Equina syndrome. Then you could also have kyphosis with local pain, and abscess may be found elsewhere, which may culture TB and may be a guide to the fact that this could be tubercular spondylitis affecting this patient, or even a tuberculous myelitis. The psoas muscle could have abscesses and may erode into the skin. So it's more common in patients with HIV, even though it does also occur in immunocompetent hosts. Only 10 to 30% of patients have extraskeletal TB in those who are affected with Pott's disease. It's primarily a clinical diagnosis in endemic countries where you see the typical gibbous. Laboratory studies, you have the skin test, which is positive in 85 to 90% of HIV negative patients. ESR is often high, above 100. Then biopsy of samples shows AFB positive with cultures in only to 40 to 50% of cases. DNA PCR amplification with GeneXpert or GeneXpert Ultra can be useful in some cases, even though the percentage positivity is not that high. So in terms of supportive imaging, a chest X-ray or X-ray of the spine could be useful. A CT scan and MRI are also indicated and would be useful. The treatment is, of course, antituberculous treatment for a period of 9 to 12 months, as well as surgery or debridement and stabilization of the affected vertebra. So we talked about poliomyelitis previously as a presentation of acute flaccid paralysis. Then we now come to the other differential of spinal cord disorders in the etiological categories, and this is demyelinating disorders. So here, patients present with sensory motor symptoms as well as bowel bladder involvement, and the onset is usually over a few days, with the exception of neuromyelitis optica. That's NMO. Then this table tends to give you the lowdown of the differential diagnosis of demyelinating disorders, categorizing them between clinical presentation, imaging features on MRI, as well as CSF findings. We'll try to talk a bit about the clinical features. So in multiple sclerosis, you usually have a partial myelopathy, like a brown cell cord, where you have a partial segment of the spinal cord affected. Then in neuromyelitis optica, it tends to be very severe deficits and usually may involve a wider segment of the spinal cord as opposed to multiple sclerosis. So you can have a typical transverse myelitis picture, and like where you would have maybe one limb affected, you could have both limbs affected in neuromyelitis optica, even though bear in mind that these clinical presentations are not absolute. And this is just a guide to try to help you narrow down as you are approaching the patient. You need to put together a number of things to concretely say neuromyelitis optica over multiple sclerosis. And optic neuritis is common, and it's common in neuromyelitis optica as well as in multiple sclerosis. So this cannot distinguish between the two. In acute disseminated encephalomyelitis, ADEM, monophasic disease is most often the case where somebody has an acute attack and doesn't have it again, and that presentation, or they could have a previous or prodromal fever or viral infection, and then this acute demyelination in the nervous system occurs. Then you could have post-vaccinal demyelinating disorders, and these are often monophasic, and you have a history of preceding vaccination in a previous 3 weeks or so. I think we did see a case of such post Johnson & Johnson vaccination at our hospital. And then sometimes they could be idiopathic. So I'd urge you to have a look at this table and familiarize with how you could distinguish between these demyelinating disorders. So here we talk a bit about multiple sclerosis and the other demyelinating disorders with how you can distinguish them. So in multiple sclerosis, usually with imaging, you have less than 2 vertebral segments involved, as you can see in the image here. I don't know if my mouse is visible, but you see small segments of hyper-intense signal, that is a signal which is much brighter than the rest of the spinal cord. Then when you look at it axially, it tends to be peripheral instead of central, and it tends to be asymmetric, and this coincides with the symptoms which are also often asymmetric. And then common syndromes like Lemmitz or Brown-Séquard could be found. Lemmitz is simply where you have a shooting pain down the neck when you hyperflex your neck. Recovery is often complete or near complete, and it takes weeks to months, and does tend to relapse or recur. Neuromyelitis optica, as opposed to multiple sclerosis, tends to have longitudinal extensive involvement of the spinal cord, where you see T2 signals extending beyond 3 vertebral spaces, as you can see in that diagram. And in this diagram, it even extends to the brainstem. Often the cord is swollen, dematters, can even be necrotizing, and there's poor recovery as opposed to multiple sclerosis. And neuromyelitis optica has an increased prevalence in African Americans, Asians, and often coexist with other autoimmune conditions. So this is another image of a neuromyelitis optica, where the axial segment of the spinal cord tends to show its rather central affectation of the spinal cord, as opposed to multiple sclerosis, which was more in the periphery. Acute disseminated encephalomyelitis, most common in children, often preceding a viral infection, as we said from that table. And it was noted that 25% evolved to multiple sclerosis, even though this was because it was, some of these cases were erroneously diagnosed as ADEM, and yet an attack of multiple sclerosis. But in children, this is where you tend to see this trend where, as they grow up, they could tend to develop multiple sclerosis. But do note that it is often a monophasic illness. MRI of the brain usually shows abnormalities, and in the spine issue, you see longitudinal extensive lesions like in NMO with cord edema, but usually without any enhancement. So these are the images trying to depict what has just been said. So other autoimmune or systemic disorders that are worth mentioning are things like systemic lupus erythematosus. So it can also involve the spinal cord as much as it just involves the skin and the joints. Even though it's rather rare, in 1 to 2% of SLE patients who have spinal cord involvement, they tend to be, just like with the overall disease, a female predominance. It occurs as the first manifestations of SLE in about 25% of cases. 2/3 occur in the setting of other neuropsychiatric manifestations, and usually are not associated with an exacerbation of SLE. Usually it's monophasic, though about 10% tend to have recurrences, and you tend to see a longitudinal and extensive transverse myelitis that is involving a long segment of the spinal cord, usually beyond 3 segments. And CSF studies show pleocytosis in more than 50% of patients, with antiphospholipid antibodies in about 50% with poor recovery. Then the vascular etiologies, we tend to look at arterial strokes, which presents as a hyperacute presentation over hyperacute to acute over minutes. And the risk factors are mainly surgery, vasculitis, cardiac or cholesterol embolism, hypertension, and the hypercoagulable state. So basically, the risk factors for strokes elsewhere tend to also be the risk factors for strokes in the spinal cord as well. And then these strokes have a predilection to the upper thoracic or thoracolumbar region, and as well as the watershed vascular distributions. Then neoplasms are also an important etiological consideration in spinal cord disorder and usually presents over weeks to months. Acute presentations with hemorrhage into the tumor or impact can also occur, and this could usually be established after you do imaging, or in a patient who has a known history of a malignancy and they hyperacutely present with sudden onset worsening of their symptoms or new symptoms of paraplegia or paraparesis. You can tend to entertain hemorrhage within the tumor. So primary tumors of the spinal cord include ependymomas, astrocytomas, hemangioblastomas, and lymphomas. And then there are also metastatic tumors which can go to the spinal cord, commonly prostate cancer, as well as multiple myeloma, even though they tend to involve the bones and will cause a myelopathy secondarily. Then in terms of metabolic or degenerative and toxic etiologies of spinal cord disorders, we tend to consider vitamin B12, which preferentially affects the posterior columns. It's an important differential. And copper deficiency, as well as vitamin E deficiency, also tend to preferentially affect the posterior columns. Even though we don't test for copper and zinc, but they are important differentials in patient with a posterior cord syndrome. Vitamin E deficiency can result from chronic malabsorption, as well as in people with the genetic deficiency. And ataxia with vitamin E deficiency is a clinical syndrome which is known and described. This is where patients present with progressive ataxia, dysarthria, and loss of reflexes, as well as dorsal column dysfunction. Then adrenomyeloneuropathy, Friedreich ataxia, hereditary spastic paraparesis are important metabolic, degenerative, and toxic causes of spinal cord disorders that are worth mentioning. So we now look at the second framework for approaching spinal cord disorders, and this is by time course. I think you'd have heard me talking about this as we're talking about most of those etiologies. So we tend to define timeframes as hyperacute. This is where symptoms develop and progress over a few minutes. Acute is where they progress over a few minutes to hours. Subacute is where it takes days to weeks. And chronic is where there's time course of weeks to months. So with hyperacute presentations, these are the differentials for an hyperacute presentation, usually trauma or an acute compression, an arterial impact, or hemorrhage into a tumor. Not that much. So you see, if you put together the presentation, the etiological classification, as well as the time course, you tend to easily know out the differentials which fall out. Then in terms of acute presentation, the differentials include hemorrhage into a tumor, pneumonitis optica, as well as vascular causes can tend to present in the acute form, depending on the history as you get it from the patient. In subacute phase, you have mostly the demyelinating disorders and inflammatory ones. So that's pneumonitis optica, multiple sclerosis, acute disseminated encephalomyelopathy, neurosarcoidosis, and other inflammatory disorders such as SLE, as well as infectious etiologies as well. In the chronic phase, you mainly have chronic infections such as HTLV1, HIV, and syphilis. Neoplastic causes are also more in the chronic time course, and then metabolic and degenerative conditions also tend to have a chronic time course. So the third framework is by anatomical localization of the presentation. So this is the anatomical framework where you have mainly, if we are considering demyelinating or metabolic differentials, excuse me, and you have a dorsal segment involvement, you think multiple sclerosis, or a peripheral involvement, think multiple sclerosis. As remember, as we said, with multiple sclerosis, it tends to have a patchy or peripheral involvement. Then in the transverse myelitis, that's where the whole segment or most of the whole segment or central lesion occurs in myelitis optica. It can also occur in multiple sclerosis as well as in acute demyelinating encephalomyelopathy, ADEM. Anterior horn ischemia is, of course, common in acute flaccid paralysis, and among those is polio cause as well as post-vaccination. But important to note that pneumonitis optica can also present with an anterior horn ischemia. Then you have vitamin B12 deficiency, which typically presents with dorsal column involvement, even though it's not complete, and it's sometimes referred to as an inverted V sign. So in terms of anatomy, as I think these were already mentioned in the previous slide, if it's central, you think of venous congestions, NMO, neurosarcoidosis. Anterior horn cells, the differential for anterior horn cells, as we discussed earlier on, then the dorsal columns tend to have a predominance of metabolic and chronic infections. So vitamin B12, vitamin E deficiency, copper and will also come in there. Then in terms of the chronic infections, we have tab-based dorsalis and HIV vascular myelopathy. The lateral cord tend to have multiple sclerosis, HTLV1, as well as syphilitic meningoencephalomyelitis. So how do you wake up a patient with a spinal cord presentation? So importantly is imaging. That's MRI is a preferred choice of imaging. Unless, of course, if X-ray shows bone degeneration, then you want to further evaluate for a Port's disease or other bone involvement. CT would be as helpful in that case, if not more than an MRI. Then a lumbar puncture to conduct CSF studies is important. And you need those tests there, as well as don't forget to include tests for syphilis as well. Then serology, you look in the blood for HIV, vitamin B12, and syphilis as well. So treatment depends, as you would guess, on the etiology. So infectious causes, it's important that you identify them and institute appropriate treatment to whatever infection it is. And ruling them out is also very important because treatments for other spinal cord diseases may worsen infectious causes. Examples of treatment for specific infectious causes include the cyclovir for HSV and VZV, myelopathy, antiretroviral therapy for HIV, and tuberculosis treatment for POTS. Then, in terms of treatment, the second thing we look at is inflammatory versus non-inflammatory. So for the inflammatory, acute treatment is with IV steroids as well as plasma exchange. Then in those with monophasic versus recurrent, you might consider, so for those with recurrent illness, you might consider long-term immunosuppressant drugs or disease-modifying drugs. But if it was monophasic, you won't have to entertain that. In the non-inflammatory category, you have things like surgical decompression, endovascular intervention, vitamin repletion, depending on what non-inflammatory cause of the myelopathy is. Thank you very much. This is the end of the slide. I would say I'd pause here for any questions, but you would have your questions deferred to when you have the in-person lecture. Please keep your questions and read up and bring your questions to the in-person lecture. Thank you very much.